For our injuries for the foot lab, there's just 3 injuries that we'll go over, and all of them are chronic gradual onsets. Cumulative overuse, trauma to the foot, rather than one acute traumatic incident. First one, plantar fasciitis, so usually associated with running, although it can occur in non-runners as well. Typically something has changed with that individual, so maybe they got new footwear, or they have really old shoes and it's time for new footwear. Or for our runners, they've changed terrain, they've increased the distance or volume of their training. So they're going to complain of pain on the bottom of the foot. The worst pain is going to be at the medial calcaneotubercle, and especially those first few steps. In the morning, they're going to have quite a bit of pain. The reason for that is when we're sleeping, our ankle naturally tends to end up in a plantar flex position, and the plantar fascia is in a slightly shortened position, so we can get some adhesions or cross links that form in the plantar fascia in that shortened position. And then when we stand in the morning and weight bear for the first time, we tear apart those adhesions, and that's what causes the sharp pain when we're first walking in the morning. We're doing our assessments. We're going to have the athlete standing with their shoes off, and we're going to look at the arches of their feet and see if we see overpronation or oversupination. And then we want to get the athlete moving functionally. So we want to get them squatting, see how the shape of their foot changes. Is it symmetrical side to side? We'll have them twist from side to side, and same thing, looking at how their feet move. And then we're going to get them to walk for us. Walk away 10 steps, walk back 10 steps, and we'll see how their feet are moving while they're walking. If it's a running related injury and say their pain only comes on after a certain length of time, maybe 45 minutes, an hour into the run, then we might need to ask that person to go out for a run until the pain comes on and see if the movement of their foot changes when they're fatigued. Running gaits assessments is difficult, especially if you're not trained in it. It's a little bit easier to see these differences on a treadmill. So watching a person from behind a treadmill, watching a person from the side on the treadmill, and you can videotape and go back and look at it in slow motion. It's quite difficult to assess running gait on somebody who's running away from you or running towards you. Other things that we'll find with our assessment: for range of motion, we may notice some decreased ankle dorsiflexion on the painful side because of gastroc soleus being tight and that fascial connection between the Achilles tendon and the plantar fascia. So your gastroc soleus length test may be decreased on the painful side. Similarly with toe movements, the big toe extension may be slightly decreased on the painful side, so your flexor hallucis longus length test may be decreased slightly. And each of those things, gastroc soleus tightness, flexor hallucis longus tightness, can alter the way that we run, and that might put increased stress on the plantar fascia. Strength is usually good side to side. We won't notice anything with strength testing. There's no real special tests for plantar fasciitis, so we'll jump right to palpation, and most of their pain is going to be underneath the medial calcaneotubercle. So when we palpate underneath the medial calcaneotubercle, they'll have discomfort. Sometimes if we palpate along the length of the plantar fascia, it will be sore. Treatments: we want to address any of the biomechanical issues that we identify. So if we notice that maybe they have some overpronation, we'll try taping the arch of their foot with their Lodi arch tape job, and you're going to do that at the beginning of Lab 4 next week. And if that increased support for the medial arch is helpful, then we can recommend insoles, initially non-custom ones, and then we'll move on to more custom orthotics or more supportive shoes. Now, if they only want more supportive shoes for running, then they can just go out and buy more supportive running shoes. But if they want more support for both their work shoes and their sport shoes, then getting orthotics might be a good idea, and they can swap the orthotics out between those different shoes. It's just in that case, for the running shoes, they're going to buy a neutral shoe rather than a supportive running shoe, because orthotics plus supportive running shoe is too much support. Police, so they might have a period of decreased activity to give the tissues a chance to heal and recover. And then we'll do some strengthening activities for the muscles on the bottom of the foot. Things like towel grabs with their foot on a towel, using their toes to pull the towel towards them, picking up marbles. They can massage the bottom of their foot with a lacrosse ball or a golf ball, or even a frozen water bottle, so they get the icing and massage at the same time. And then we'll move on to more weight-bearing activities, single leg stand, and we can ask them to try and create more of an arch. So think about drawing your big toe back towards your calcaneus. When you do that at home, you'll find that you get a bit more of a medial arch, and then asking people to maintain that higher arch while they're standing on one foot and doing different balance activities. Our balance proprioception exercises are automatically going to strengthen the muscles on the bottom of the foot, so we'll introduce some of those. And then it's our gradual return to running after that. So pool running, shallow ends, moving on to walking, softer surface running, so the inner turf field rather than the outer track, before we move on to the harder surface running, and then we'll gradually increase their distance and volume of training. For fat pad syndrome, again, a chronic gradual onset injury, usually associated with older athletes, and that's where our masters runner comes from, so over 40 years old. They've done a lot of repetitive pounding on hard surface, then that collection of fatty tissue underneath the calcaneus will thin out, and more of the impact is being transmitted through to the calcaneus, so the bone itself can get bruised. So they'll complain of pain right underneath the calcaneus. We may identify some other issues with their biomechanics, decreased range of motion with ankle or big toe. We may note that their shoe is quite worn, or they don't have proper shoes for their feet. So we'll address that in our treatment. Rests, the heel cup. We'll try the fat pad tape job first. I'll do a videotape of it. It's a very simple tape job. All it does is kind of squeezes the fat pad together underneath the bottom of the calcaneus and makes it a little bit thicker. If that's helpful, then you can recommend the heel cup, which is just a cushioning insert that goes into their shoes. And then our gradual return to running, as we described above with plantar fasciitis. Heel spurs is related to chronic plantar fasciitis. So somebody that's been dealing with plantar fasciitis for months and sometimes years, and that continued pull on the plantar fascia at the medial calcaneal tubercle where it originates on the bottom of the foot, your body responds to increased stress in an area by laying down more bone. So we'll start to see this bony spike that grows out away from the medial calcaneal tubercle, and it'll show up on x-ray. Their assessment is going to be the same as it would be for plantar fasciitis, and our treatment would be the same as it is for plantar fasciitis, as described earlier. Now, if their symptoms are not resolving with our conservative treatment, they may do surgery to remove that extra bony growth. It's just if we haven't addressed the causative factors and there's still that stress on the plantar fascia, the bony growth is just going to come back again. So they try to avoid surgery as best they can. I will let you know that you are not responsible for heel spurs on the injury scenario at the end of the semester. Out of all the injuries that we cover, we eliminate 3 of them because they're x-ray diagnosis, and that's the case with heel spurs. Is we usually don't know people have a heel spur until we do an x-ray. So you guys aren't going to have an x-ray machine at home when you do your injury scenario, so you do not need to worry about heel spurs for your injuries. So that's it for the injuries for the foot lab.